Good afternoon and welcome to the Healthcare panel at the Spears Wealth Insight Forum, held in association with the London General Practice. I'm Thea Halstead, the Head of Luxury and Editor at the New Statesman Media Group, and today I'm joined by Dr Paul Ettlinger, the Founder and Medical Director at the London General Practice, and Dr Catrin Bevan, Safeguarding Lead at the London General Practice, who specialises in women's health. Dr Ettlinger has a particular interest in preventative medicine, and in today's world it really goes without saying that keeping you and your family in the best medical shape possible can be life-saving. One of the ways of doing this is through regular and robust healthcare screening. This helps identify early signs of disease and health issues, and thus enables early intervention and basically opens up greater options for care and a better chance of recovery, or at least disease management. One of the numerous challenges we're going to face in a post-pandemic world will be as a result of the money and resource being shifted to focus on COVID-19. So the pandemic is actually holding back other treatment development. And along this theme of the long-term challenges that the pandemic has created is the issue that patients have been nervous about seeking medical attention for other issues, whether they're apprehensive about seeing their doctor or just so focused on looking out for the symptoms of COVID-19 that they're ignoring red flags that would previously have sent them straight to their doctor. Dr Ettlinger and Dr Bevan, thank you so much for joining us today. It's hard to have a discussion about health without addressing the question I imagine everyone is asking you at the moment. And Dr Ettlinger, if you wouldn't mind answering this, so what advice are you giving people regarding ways to maintain and optimise their health at this time?
Well, good afternoon, and thank you very much for inviting us to the forum. I'm wearing a face mask, but as it's virtual instead of real, I might as well take it off because there isn't anyone else here at the moment. I must say I would encourage everyone to follow government advice about face masks. I think the issues here are clearly that one wants to remain healthy. And in doing so, I think that it is really important to look at your weight, look at your alcohol intake, look at your exercise, and actually remain healthy. And I suppose healthy doesn't also mean physical health. It might mean a mental health, because unfortunately during this period, I think we are seeing an enormous number of unhappy people for all sorts of reasons. And that can be because of their lockdown with, say, unhappy spouses or unhappy situations, or of course now we're going to have a lot of people who unfortunately won't have any work. So I think we've got to look at both mental and physical health in order to actually maintain a healthy lifestyle.
Okay, and Dr Bevan, touching on the mental health issues, I mean, are you seeing a lot of people that are really struggling with the isolation?
Yes, we are. Not quite so much now that lockdown has finished, but there was a lot of unhappiness during lockdown with people's increased mental health deteriorating. Just to go back to what Dr Ettlinger was saying regarding staying healthy, when we're discussing diets, we've also found, as people will have probably read in the media, that maintaining your vitamin D and your zinc levels is also essential to help ward off COVID. They found that vitamin D helps stave off infectious diseases, especially upper respiratory tract infections. So it's very important now that we're going through winter and everybody's vitamin D will be falling, especially because we won't be having any holidays, that people do maintain a good vitamin D level. They can get this checked with their doctor.
And is that as simple as sort of buying zinc and vitamin D tablets, or is that sort of something that you'd want to go to a doctor to actually get sort of stronger medicine? Or?
Well, people are quite surprised at how low their vitamin D levels can go. So we would encourage people to come and have their vitamin D levels checked. We would then put them on an appropriate dosage of vitamin D, and then we would recheck it again in 3 months' time.
If I could add, I think that I always get a comment about patients who actually live in sunny climes, and they say, well, we're in a very sunny climate and, you know, surely we get enough vitamin D. Well, the fact of the matter is we're not actually walking around in the nude. And if one thinks about our friends who live in the Middle East, they're actually very covered up. And in fact, they probably have the lowest vitamin D levels in the world. So in fact, although one might live in a sunny climate, one does not get enough vitamin D. And I think it's really important to check your vitamin D levels, because then we can actually give the appropriate amount of and dosing of vitamin D. You can actually overdose on vitamin D. So I think it is important to be clear that you get the right amount. And we want to keep the vitamin D at a high level. We don't want it at the low normal. We want it in the middle to high range.
Okay, fantastic. Or just people need to walk around more naked.
Well, I don't know in this English whether that's actually going to be something that we're going to enjoy. Although I believe there are naturist camps in the countryside.
And I mean, aside from COVID itself, the pandemic has affected access to healthcare in general, hasn't it? So, I mean, Dr. Bevan, how have your clients been affected by this?
So during lockdown, it was extremely difficult. As you know, people didn't want to come to the doctor. They couldn't come to the doctor. There was a huge amount of fear associated with coming to any medical establishment. All our normal screening was difficult, and we were seeing just quite a lot of medical emergencies, as well as dealing with all the patients with COVID. So yes, our normal practice was greatly affected. Now, fortunately, people are coming back, and the screening and seeing patients on a regular basis is going up. There, of course, is the fear that there's going to be another lockdown. So people are very keen to have all their investigations done in a very short time period, which we're organising, of course, to get it all done before we have another lockdown, if that is going to happen, which I hope it doesn't.
I'd like to give you some statistics, actually, because 43% of patients who should have been referred during lockdown for cancer did not get screened or did not get referred. So we're talking about 210,000 people a week during lockdown did not get referred to the appropriate services. 76% of patients didn't get any diagnostic testing. Now, of course, we were talking about National Health Service, but that can reflect also into private care, because it was quite difficult at times, although we were able to access private care. Treatments fell by 40%. Our life statistic now is the same, with Great Britain's life statistic is now the same as Lithuania before the pandemic. So our actual health statistics have decreased substantially. And I think this is very worrying for the United Kingdom and for a considered non-third world country. Not that I say that Lithuania is a third world country, of course.
And do you think this is because the NHS is overwhelmed, or because people aren't coming in?
It was really because the NHS was stopped. It wasn't a question of it being over, because actually if we looked at the Nightingale Hospital, I think they only had 53 beds taken up during that period, and that was a hospital for 4,000 people. So I think that actually, I think that what happened was there was such a fear that, having seen the scenes and what happened in Italy and throughout the other European countries before the pandemic reached us, that there was such a fear that the services would be overwhelmed, that everything just got stopped. And so, unfortunately, one of my colleagues, who's a very senior urologist, was not allowed to do a simple blood test for prostate cancer, not allowed to do it, because if it was abnormal, he was not able to offer them any investigation or treatment, which is terrifying. And
is that potentially life-threatening?
Well, if the prostate, there's a controversy about the prostate-specific antigen blood test, but actually, if used and understood, it can be a very useful tool to diagnose prostate cancer. Yes, because if someone had a very abnormal result which required investigation and required treatment, as in you found a prostate cancer, then that person does not even know, may still be walking around now not knowing that they had prostate cancer. I think Catrin will probably discuss women's health, but I think the same was of mammograms or treatment for breast cancer. That was delayed or stopped. They were rationed. Our oncologists had to make decisions as to who could have treatment. I don't know, Catrin, if you have anything to add there.
Well, they estimate that 30,000 people will die from undiagnosed cancers. 30,000. I mean, the death rate from COVID is going to be in the 40s, probably will reach 50,000. But, you know, the untold deaths from other illnesses is huge. They've also found that diabetics, because they didn't go for their regular checks, there have been increased amputations occurring in many diabetics because they haven't had their regular diabetic checks over the last 6 months. So the repercussions of this are enormous.
Cardiovascular disease. Patients weren't having access to angioplasty, weren't having access to, if they needed coronary bypass surgery. I would not like to think where those patients are now. Patients weren't going to be diagnosed with cardiovascular issues either. So those patients are either sadly no longer with us, or actually are waiting in a system which still probably hasn't reached up with them.
And I suppose looking even sort of further forward to the future, if funding into research and development into diseases has been cut, then we've got to think about the deaths that could be come across as a result of that.
Well, I think only yesterday AstraZeneca said in the Times that they had noted a decrease in funding and the availability to trial other non-COVID research projects. And I think this is a big issue because obviously all the funding and all the resources and considerations are being put towards COVID rather than thinking about other cancers, other treatments. And this is where I think screening now, health screening now, is so important. And I think that we really should be trying to encourage everyone who has the ability to actually health screen and actually let's look for these. We want to find a problem before it becomes a problem. If we can find the problem before it's a problem, we can offer treatment and possibly and probably definitively cure.
Okay, so I suppose as the healthcare landscape has been changed so hugely by the pandemic, screening is one of the ways that people can sort of help themselves and their families not be hugely adversely affected. And in terms of healthcare screening, what age, when's an appropriate time to start?
Any age. Yeah. We try to cater for all age groups. Some people want to start screening in their 20s. Other people don't think about it until they're in their 50s or they've had some sort of health scare or their family has had a scare. But at any age, we try to customize all our screening on an individual basis. So it's not one screening fits all. It depends on your age, your health, your family history. There are numerous things that go into our health screening to make it very personal and individualized.
I think this is really important to say, and I think that we should also stress that we do individualize and personalize a health screen. I think it's possible that you could go to large organizations or insurance companies which run health screening programs, and they will actually they will have a one fits all rather than an individualized program. I think it's very important that all health screening is evidence-based and all our programs are evidence-based, so that we're not going to expose anyone to radiation, CT radiation, unless actually the benefits outweigh the exposure. Nowadays, of course, the CT scanning machines have a very low dose of radiation, and they're very, very highly selective, and they're the actual resolution of the scans are incredible. But we wouldn't want you to have a scan unless it was indicated. So I think it's very important that whereas if you go to some centers where they have the machines, sadly, they need to pay for the machines. So that's why you might have a scan. I think going back to the age groups, I mean, we would suggest that if you are sexually active and you're a female, you should have cervical screening from the age of 21. The American Cancer Society suggests age of 25, but I think that if you are actually sexually active, then there is no reason not, and with your own support and consideration, you should have a screen from the age of 21. And as Catrin said, family history is so important now, that you don't say, well, we would do a screen at this age. You do a screen, let's take into account your family history. If you have a family history of cancer of the colon, recommendations for asymptomatic patients with no family history is to start colonoscopies from the age of 45. But if you have a family history, we would certainly consider it earlier.
Okay, and Dr. Bevan, do you have anything to add to that?
No, I do a lot of female screening, so I'm very passionate about women coming in and having their mammograms from the age of 40. If they have a strong family history, I would also refer them to see a geneticist. On the NHS, they start screening from 50 every 3 years. We would prefer to, like most of Europe does, to screen from 40 yearly. And also to make women aware that they can have ultrasounds as well as mammograms at the same time. Different investigations show different things.
And I think it's important to say on that, actually, that if you have a strong family history, you would be actually offered an MRI scan prior to the age of 40, and you could even start at the age of 30 if you have a strong family history of breast cancer. And it depends also on the age. If your mother sadly had breast cancer, it depends on the age of onset that she had her breast cancer.
Okay.
So again, this is where the individualized approach is so important. Because if you don't individualize and you just have very rigid guidelines, I think the guidelines have to be clinically evidence-based, but they have to also be suitable for the patient.
And oh, sorry, carry on.
Sorry, just to add to that, when we do screening, we not only screen the patient there and then, but we also give them recommendations and guidelines as to what they should have going forward. So if we say yearly mammograms, transvaginal ultrasounds, you know, DEXA scans for osteoporosis, we then, and colonoscopies, of course, or CT colonographies, we would give them a guideline so that they would know. And then when they get their medical, they have a nice booklet, they can refer back to it, they can see, oh yes, I had my mammogram in September, I need to have another one in September. We, of course, send them the reminders to have them on a yearly basis because, you know, time goes very quickly and people forget when they should have their screening, how often they should have their screening. So it's very reassuring, I think, for people to have screening and to know that we're looking out for them and that it's all being planned and sequenced for the future.
Yeah, I'm sure that takes out stress from a very stressful situation. And in terms of sort of self-diagnosis, how harmful is that? People go online and type sort of symptoms into Google.
I think that we have to all be aware that whatever we might say, a patient will be doing that. But I like to look at an analogy of if I have a legal situation or if I have an accounting situation, I'm going to probably not look online because I'm not someone who has time to necessarily do that. And I would refer to an expert. And I think that's the analogy that I like to say. I think there is no harm in looking online, but of course one might not have the wherewithal necessarily to actually interpret what one's seeing online. I think it's always useful to have ideas, and certainly I think we're a great believer in the practice that we work with a patient to manage their health, and the health of the patient is what might be suitable for you as a treatment or as indeed even as an investigatory tool is not necessarily suitable for the next person. So we work with a patient to determine the best advice and the best way forward. But actually you can look online and then you can actually, let's be frank, especially in this day and age when everyone is at a slightly heightened anxiety, you can actually get yourself more worried.
Yeah. Dr. Bevan, have you got anything to add to that?
Well, people can cause a lot of anxiety for themselves by looking at things online and coming to the incorrect conclusion that they have something very serious wrong with them. I mean, almost worse is when they look online and they think, oh, it's nothing serious, I won't bother going to the doctor. They don't go to the doctor. They then have a delay in their diagnosis, which can be, you know, life-threatening and, you know, have very severe, you know, consequences in the end if they haven't had an early diagnosis. And we have seen this happen during COVID.
Okay. There's been a recent boom in healthcare provision and technology. How will this change the service provision moving forward? Dr. Ettlinger.
Well, I think that there's, of course, all technology is to be encouraged. but then it's got to be utilized appropriately and it's got to be understood. Now, certainly we've got data, and I think data at the moment is a very useful tool to try and understand the management of a population and also how you might treat that population. And during this situation of the pandemic, we've had every single day, we've had data on, the number of cases, the number of deaths, etc. This data, that's the sort of population data. And of course, we're going to have data technology where we're going to we can look at our Apple Watch and it's taking all these readings. But the issue there, of course, is who is looking at that and helping you interpret it. And I don't think at the moment Apple have worked out a solution there. I think there are data platforms that are coming through which will actually go through to a panel of experts, and then that panel of experts will help you to define what's important to you. I think the other issue with data is that, well, certainly on the data front, is that it's tended to be towards populations. So you can actually manage a population's health with large data, but it doesn't individualize it. And I think, again, this is something where some of the new technologies and the new platforms that are coming through will be individualizing data to actually help you look after your health. Going forward, I mean, we use algorithms in the practice to help us to assess your risk. So we use, there's an algorithm for lung cancer, which, I mean, the traditional thought was always that lung cancer, well, or the traditional thought is, although the American Tobacco Association probably won't agree with us, is that the lung cancer is caused by smoking. And I think whether we like to agree with that or not, the facts are there. Lung cancer, smoking causes lung cancer. But actually, in Japan, and well, in China rather, so in China, there's a large amount of lung cancer in females who don't smoke. So that's an interesting thought. Why would there be a large amount of women having lung cancer who don't smoke? And the interesting thing is, it may be because they're in the kitchen, and it may be cooking oils, it may even be hairsprays. We don't quite know the answer to that. But this is an interesting, so we have an algorithm now which can help to assess your risk and takes into account all sorts of variables: family history, age, education, your what you do, your job, which helps to give a value, which then can decide whether you need to screen for lung cancer. I mean, lung cancer, I think, is one of the most devastating cancers, because on the whole, it's discovered very late. If you see a lung cancer on a chest x-ray, sadly, that's probably too late. Whereas if you see a lung cancer as a tiny little nodule, which might even be only 5 millimeters on a CT scan, that's treatable. You can cure a person because you can remove it. So I think that the way that one can look at these situations, you can't actually necessarily say that you should just think of traditional causes. You need to actually try and have algorithms now. There's an algorithm for cardiovascular risk, and you can decide whether someone has a significant cardiovascular risk and then should be either offered further investigation or treatment. And then, of course, we've got you. Sorry.
Is that something that the NHS have access to, or is it?
Well, they would certainly be using the tool for the for cardiovascular risk, but of course, the other situation would be that they would set the standards quite high in order to actually either, well, they probably wouldn't have access to the investigations. They would just start the treatment. So they would set that actually it's a 10% risk of having a cardiovascular event would result in the starting of a statin. But that doesn't actually wouldn't have an investigation. You just have an algorithm which would give them a risk, which would mean whether you start treatment. For the lung cancer evaluation, there probably isn't done any of every single. So it's probably still a research tool or still being looked after, so being researched. So no, that probably isn't done by every general practitioner.
Okay.
And I think it wouldn't be done in private practice either, because again, I think because we try and gear everything to the patient, not because we've got them, well, we don't have the machines. And that's another aspect, I think, of the practice, that we can use the very, very best machines available, which are then interpreted by the very best specialists in their fields.
And Dr. Bevan, sort of talking about sort of technology and women's health in particular, is there anything that sort of you know, coming up through, you know, through the ranks that you're sort of particularly excited about and you think will sort of be a game changer?
Technology-wise, not so much. I think, just to briefly go back to what Paul was saying, when we're doing our screening, we have the benefit that if people have raised cholesterols and they are uncertain or not happy about going on statins, then we send them for further investigation, CT, coronary angiography. And that enables us to see whether having their high cholesterol is actually affecting their coronary arteries. And then if it is, then we can let them know, and then they have a very good reason to be going onto a statin. So we try to make it so that everything has a purpose and a reason. You know, we don't just put people on statins. You know, there's still a lot of controversy regarding them. So we try to encourage people to have investigations so that when they know that they have got blocked coronary arteries, then they're very happy to go onto a statin and stay on them and take the medication instead of going on and off them as some people do. So that's just another way that technology can help us. More investigations. We're very fortunate that we can do that. And also we must remember that coronary artery disease and strokes are very much up there for the reasons that people get sick and they die. Everybody thinks that it's cancer that we're going to die from, but actually coronary artery disease. And especially for women, men get investigated more in their 50s and 60s from the point of view of coronary artery disease than women do. And so I'm very keen that women, if they've had a previous history of smoking or they have got high cholesterol or high blood pressure, that they come for screening so that we can make sure not only that they don't get cancer, that they don't get a heart attack or stroke, that we can try and prevent it.
And what are the telltale signs, Dr. Bevan, that people should be looking out for, especially now when I think we are feeling a bit more nervous about going in to see a doctor?
Sorry, telltale signs?
Or that sort of indicate a serious health
disease.
Right. So, well, we try to encourage people to come to the doctor before they have the telltale signs.
Yeah.
But typical signs of when something is seriously wrong is bleeding from anywhere, a lump, fatigue, weight loss, pain, you know, the really serious things that you would normally go to a doctor about. I mean, we do encourage people, if they have any change in symptoms or they're not happy about anything, they should try to seek medical care sooner than later and not leave it.
And how is sort of having Zoom and video consultations, what are the long-term effects of that, do you think, Dr. Bevan?
Well, I think during the lockdown, Zoom and consultations were very useful. Telephone consultations, of course, we've been doing in the past. I've been a doctor for 30 plus years, and nothing is better than seeing a patient in the flesh. And sometimes you can't diagnose things on a Zoom. You can't read between the lines. You know, we take a lot from how the patient walks through the room, the color, how they're acting. There are too many little things that, I mean, my preference is that we do face-to-face consultations, which we have been doing since the end of March.
And I mean, Dr. Ettlinger, I'm sure that a lot of your clients are sort of traveling a lot in their normal lives. How do you get around that?
Well, I think that if we have travelers, I think, which we have a lot of, I think it's very important, as you know them, that you can offer them actually Zoom calls or telephone calls and help them with their health. I mean, I was actually dealing with someone with COVID in Saudi Arabia, and he didn't speak English either. He only spoke Saudi and Arabic, and I was able to help him during this period with the help of his son, who was an interpreter, to actually go to hospital, because we monitored him every day. We offer a COVID safety net service, whereby if unfortunately one of our patients is diagnosed with COVID, we offer them a service where we speak to them every day, 5 minutes, just a quick 5-minute call every day to see how they are. And we also offer a pack which covers a pulse oximeter, a sphygmomanometer for blood pressure, and a thermometer to actually help us to help assess them. this patient had actually seen his own doctor in Saudi. His own doctor wasn't worried about him, but his oxygen saturation had gone down to 93%. And I was monitoring every day. And I said to him he had to go into hospital. He indeed had pneumonia. And he's very grateful because he's now out of hospital and feeling extremely well. So I think those are issues that there's an example of how one can look after patients wherever they are in the world. And that's what we like to do. We also have built up actually great contacts with the leading specialists and leading doctors in many countries throughout the world, in many cities throughout the world. And so we can readily call upon someone who needs to help. I mean, there is nothing, as Dr. Bevan says, there is nothing like a face-to-face, hands-on consultation. I think from my experience of when I had hair, so that's a little bit longer than Dr. Bevan, I can say that you know, you just know when someone comes into the room, you feel whether someone's got a genuine illness and is really needing further investigations. And I think that's where, if you know your patient and they are anywhere around the world, you can actually help them to look after them. We do sometimes provide, you know, emergency medicines for them to take with them so that they've got that. At the moment, I'm actually working with one of our leading cardiologists at the Royal Brompton to consider a sort of pack that patients can take if they get COVID. And we're working on that together to actually put a pack together, because the drugs that you might want to give to someone with COVID can in themselves be quite, cause quite serious side effects. So you don't want to just give it to someone, but we're working on a protocol actually for this, because unfortunately I do think that we are going to have more patients now having COVID disease, and as a result I think we need to be prepared for that.
Okay. And
this is where we can help our patients. We speak to them. We're always available. I mean, our telephone numbers are always answered. We don't have people. We don't have answering machines. We have real people answering the phone. I always have them available on my phone. I used to say, except if I'm at the theatre or on a plane, but that doesn't happen very much anymore. So we're always available to answer our calls and help our patients. And I think we are going to see, as I say, unfortunately, this week I've already had about 5 diagnoses of COVID disease. We offer a service whereby we send a swab out to the patient. Unfortunately, we don't use National Health Service laboratories. And in fact, the private laboratory that we use does no National Health Service work and actually offers a very speedy turnaround, 24 to 48 hours. And in fact, all the results that we did yesterday, all the tests we did yesterday, we've already had all the results back in. Okay. But unfortunately, as with all laboratories, they're all under pressure at the moment. So there isn't a guaranteed timeline, but we are achieving good results on that. But we're also seeing more cases, unfortunately.
And what are your views on the antibody tests? Is that going to be a viable way of managing the disease?
Well, I think the antibody test is very interesting. And I think that the commonly known one was the Abbott test. And the Abbott test gave a negative or a positive. And all the regulatory bodies around the world set the level of detection at a very high level, because they didn't want patients to get a full sense of security of having had the disease. So actually, you could still have had the disease and yet be called negative. So there's an issue there. That was the Abbott test. The Abbott test also only checks for IgG. And in fact, when you get an antibody response, you get what's called an IgM antibody response, which they said used to be the early one. And then later on, you get this IgG antibody response. So the Abbott test only tests the IgG. Interestingly enough, we're finding that some patients only have an IgM response. So the Abbott test would say they would actually give them a negative result because it only looks for the IgG. So I think there are various tests coming along. There's another very sophisticated test from Imperial College, which we have access to, which actually measures both IgM, IgG, and the actual level of antibody, which is a very interesting test. And that would give much more information and would measure whether one is positive or one has been exposed. That test also looks at the spike protein, because there are different antibodies to different proteins. And this particular test looks at that spike protein that we've seen on the news every night over the last few months. Now, that actually is not the neutralizing antibody. What one needs to actually look for is the neutralizing antibody. There aren't any commercially available tests as yet which can provide information about the neutralizing antibodies. They're certainly being done in research tools, and certainly the Imperial College is working on looking at, using tests looking at neutralizing antibodies, but there isn't a commercially available test as yet. There will be, I think, soon, and that's going to be much more informative because it's the neutralizing antibodies you need to actually get rid of the virus, so that helps to know whether you've got immunity. Saying that, there have only been 3 or 4 reported cases of reinfection of patients or people out of 23 million people who've had the disease. So there are other factors at play. There's something called the humoral T-cell humoral response, which we're not measuring. So indeed, and we're not also measuring IgA. The IgA antibody is the antibody that's produced in the nostrils and the mouth. It's in the mucosa. And that may well be at a good level in those patients who don't get COVID, or indeed who get COVID but don't get it very badly, because that IgA antibody in the nasopharyngeal areas might actually prevent the virus getting in the first place. Okay. So there's a lot of work on antibodies. I think and the pinprick tests are valueless. Their specificity and sensitivity was extremely low, and they were quite rightly so banned, actually, I think, in the end by the government, by the PHE at some stage. So the pinprick test I wouldn't recommend. The Abbott test is a good test, but it doesn't mean, if it's positive, you've definitely been exposed. Doesn't say you're immune, but if it's negative, it doesn't mean you haven't been exposed.
Okay. Well, I think what I'm going to do is go to the audience now for questions, because I'm sure that everyone would like to take advantage of having 2 people such as yourselves at the end of the phone. So thank you so much, both of you, and thank you to the London General Practice for sponsoring this discussion. So yeah, I'm now going to open it up to the audience for questions.